So today we presented the final overall and progression-free survival results of the Phase III randomized study AGO-229 ENGOT-ov34. And maybe to give you a background of the study, it was a study investigating immunotherapy in platinum-resistant ovarian cancer. And thus far, single-agent immune checkpoint inhibitors in that setting have very limited activity, unlike in other entities. So this is why investigators have been trying to combine immune checkpoint inhibitors with chemotherapy, bevacizumab, and even PARP inhibitors, because there's a biologic rationale to combine these agents via the induction of immunogenic cell death and also the increase in T-cell infiltration by inhibiting VEGF-A and also the inhibiting the immunosuppressive profile or activity of angiogenesis and VEGF-A. And this is the basis that, of our study. So the AGO-229 ENGOT-ov34 was run in a platinum-resistant setting. Paclitaxel and pegylated liposomal doxorubicin are standard of care treatment options, and if you add in to chemotherapy bevacizumab, this will increase response rates, progression-free survival, and also improve health-related quality of life. And so this is what we did in AGO-229 ENGOT-ov34. It's a randomized Phase III placebo-controlled clinical trial. It included patients with a first to second relapse with epithelial tuber ovarian cancer with a platinum-free interval of less than 6 months. It also allowed patients with a third relapse regardless of platinum-free interval. Patients had to have a biopsy, a recent biopsy to be included, and also an archival biopsy to be included. And they were allowed to have prior treatment with bevacizumab. We stratified by prior lines of therapy, the planned chemotherapy. They could receive either paclitaxel or PLD, so pegylated liposomal doxorubicin, within the study. And we stratified also by prior bevacizumab use. With an amendment, we also stratified for PD-L1 status. So we randomized 574 patients to either receive atezolizumab or placebo in combination with the chemotherapy and bevacizumab. And the primary outcome, primary endpoint of the study were overall survival and progression-free survival. At a maturity of 88% of events, we saw that the addition of atezolizumab to chemo and bevacizumab did not increase progression-free survival. So the median progression-free survival in the atezo arm was 6.4 months, and in the placebo arm was 6.7 months. Similarly, if we look at the overall survival data, we saw at a median follow-up of 27 months that the addition of atezo to chemo and bev did not significantly improve overall survival. So there was a median overall survival in the atezolizumab arm of 14.2 months and of 13.0 months in the placebo arm. That corresponds to a hazard ratio of 0.83 with a p-value of 0.06, so just slightly off the statistical significance. However, so it didn't meet its primary endpoint, but we saw some signals of activity in terms of longer duration of response. Response rates were similar in both treatment arms, but the duration of response was numerically longer in patients receiving atezolizumab, where it was 8.6 months compared to 6.1 months. Also, if we take a look at the landmark analysis of OS at 24 months, which is shorter than the median follow-up of 27 months, we see that there is a 8% difference in overall survival favoring the addition of atezolizumab, and the Kaplan-Meier curves stay separate until the end of the follow-up time. So these results are actually quite similar to what we've seen from other Phase III trials run in other settings, like the platinum-sensitive setting, where we've known results from the Atalante study. No improvement in PFS, but a trend, I would say a strong trend for OS. My bottom line of these studies, including IO as a single IO approach combined with chemo, bev, and even PARP inhibitors, is that they're not enough to really change the clinical practice. But we see clear signals that there is a minority of patients benefiting from these approaches. The problem is that we're not able to really identify these subgroups. We also looked at PD-L1 status, which was a stratification factor. We saw that in our study, AGO-229, ENGOT-ov34, PD-L1 status did not impact the efficacy of atezolizumab. So clearly, to move forward, I don't think that hope is completely lost for IO in ovarian cancer, but we need novel approaches, not just taking one immune checkpoint inhibitor and then combining it with chemo or other targeted agents, but we need probably something else to boost the immune system, like a dual checkpoint inhibitor blockade. There is good signals from clinical trials that might help to increase efficacy, or otherwise like genetically engineered cytokines, IL-2 for example, or vaccines. There's a couple of studies ongoing with a vaccine approach combined with immune checkpoint inhibitors, which I think are quite interesting. And I think the elephant in the room is also the combination with the novel ADCs that are coming up also in ovarian cancer. That's my take home from the results that we presented today.